Good evening, friends. It takes a lot of pleasure and privilege to meet you in all this evening program, the flagship of the Indian Association of Gastrointestinal Endoscopic Surgeons academic activity, the IAGES Prime Time. During this prime time, we showcase the best of the talents across the globe, and we will have the most eminent, experienced, high volume center surgeons sharing their thoughts about some specific niche area of minimally invasive surgery. Ladies and gentlemen, we have two eminent speakers and two most eminent moderators for this program. Can I have the honor of inviting Dr. Deep to give a brief about the program? Then we will listen to the president. Dr. Deep, please.
Thank you, Dr. Kanakbel, and I thank all of you to this program. Prime Time, as you know, is our jewel in the crown for IAGES. It is an outreach program for the people from out of India. And today's topic is an anti-reflux surgery and whether endoscopy is emerging as a better option than the surgery. Also, we have Charu here who's going to speak about revisional anti-reflux surgery. People who have already had procedure and they have failed. What is the role and what are the precautions when you do revision anti-reflux surgery? And as Dr. Kanagwal said, that we have two very eminent speakers today, Dr. Ian from Hong Kong and Dr. Charu from US. So I welcome you all and I hope you enjoy this event. And now I hand over the meeting to Dr. Deepraj Bhandarkar.
Before that, sir, sorry. We like to have the honor of inviting the president of the IAGES, Dr. Ishwar Murthy, sir, to give his talk. Dr. Ishwar, please.
Thank you. Thank you. My dear friends, IAGES Primetime viewers across the globe, ladies and gentlemen, it's indeed a great pleasure to invite you for our second edition of this IAGES Primetime for this academic year. I welcome on behalf of all our presidents of IAGES and all my EC members. This year, as you all know, we have safety and excellence and innovation as our motto. And as an IAGES, we have been having various fellowship courses. And one such important thing is conducting IAGES webinars, IAGES Primetime, IAGES SARC webinar, and we also have with the UK IAGES GBI webinar. And today we have pleasure of having our chairman Deep, along with Raman Goyal, Satish Midha, with the convener Kanakavil, to have an excellent program on anti-reflux surgery. And I request both our excellent moderators, Dr. Deepraj, my close friend, and Ajay Kriplani, to moderate two important sessions. One close to my heart, whether endotherapy, how effective in the anti-reflux, and also for a redo or for failed anti-reflux surgery, what we can do. In the meantime, as a president, it's my pleasant duty to invite you. We are running various fellowship courses. The first time in our country, we are going to teach all of our surgeons in the art of colonoscopy and 4G colonoscopy course. And we'll be traveling to Mumbai to have the advanced fellowship course in the hernia. Then we'll be going down south to Pondicherry in JIPMER to have the upper GI advanced fellowship courses. And also, I wanted to invite you all, if you are all willing to join us in the journey to Edinburgh to have the first Indo-UK Surgicon and a collaborative conference going to happen in October. Please register. And as you can see, the website is open for registration. And we'll be traveling to the City of Lakes in Bhopal sometime in late October for our midterm conference. Finally, in the tenure of all of us will come by this academic year in Chennai to have a beautiful annual event along with the convocation in Chennai in February 1st to 4th. So a lot to look for because IAGES is now going into more stage and we are planning to host the World Congress of Endoscopic Surgery in the later part of the 2024. With all these things, I welcome you all for this wonderful webinar. I'm sure it will be wonderful with two great moderators and two great speakers. Over to you, Kanakavil. Thank you.
Good evening, friends. Dr. Midha, sir, can you bring in Dr. Deepraj, sir, please?
Good evening, everybody. Dr. Deepraj Bhandarkar is one of the senior members of IAGES and one of the practicing surgeons in Mumbai. And he has also been the chief editor for our journal JMAS for quite long time. And he has been inspiring with many youngsters. So he'll be the moderator for the first talk by Dr. Wang. Over to Dr. Deepraj Bhandarkar, sir.
Thank you very much, Satish, and good evening, ladies and gentlemen. It's a pleasure indeed to have you with us today for this excellent session. May I share my screen for a moment? Just like to show one slide to introduce Professor Wang.
Dr. Deepraj, there is a request from Dr. Charu.
Yeah.
I'm going to ask you and Dr. Wang. It looks like there is some emergency for him. So he is requesting if he can speak as the first speaker. Professor Wang, is that fine with you?
No problem.
I'm sorry about this last moment change. This is a request from Dr. Charu. Apparently, he is on call for the day, covering up from some other person. So Dr. Charu will go first. Deepraj sir, kindly excuse me for this last moment change. And we have Dr. Ajay Kriplani sir. He's still not joined. Okay, I think I will do the honors for Dr. Charu. Dr. Charu Paranjape is Maharashtrian by birth. He had his education from India in the undergraduate period. And later he moved out to the United States. And right now he is into the heartburn program. And he is an associate director of emergency surgery. And he is a very popular figure running back-to-back programs on Harvard Mint. Mint is the very coveted program on foregut surgery, which happens every year in the month of September. And he himself is an eminent anti-reflux surgeon, and his heart beats for benign foregut surgery along with hiatal hernia surgeries. His center has done many basic, advanced, and revision works on foregut surgery. Can I have the honor of inviting Dr. Charu Paranjape to give his talk?
Thank you so much for that kind introductions, and thank you, Dr. Professor Wang and Dr. Bhandarkar, Dr. Mida, Dr. Goel, and everyone else for the opportunity, and also letting me go first. Sorry, I have to go at 11:30, covering for another colleague of mine, but appreciate again. I was asked to give the talk on redo surgery, so I'm going to quickly share my screen, and give me 1 second here. Can everybody see my screen?
Good to go, Professor.
Okay, thank you. So basically, before we approach the redo hiatus, as we all know, it's one of the most challenging sort of field in terms of surgery. It's mostly the analogy that we very often give is like archaeology, that you have to keep digging at the same time preserve what's underneath. And the challenges of redo hiatus are following. First of all, the adhesions from the previous surgery. There is a change anatomy, and so you have to really know what the change anatomy is. There is many times changed physiology. We'll see a video today which shows one of the challenges. The landmarks come without any kind of notes from a Netter's atlas, so as to say. You have to really think about how you're going to reconstruct if you're going to reconstruct. The other technical challenges are many times the previous records and operative notes become the Bible of how you're going to redo or sort of approach the redo hiatus. You have to also think about imaging that's old as well as new. What new imaging you're going to do. You have to define the landmarks in a new field, and always you have to have plan A, B, and maybe even C. And lastly, I'm going to touch upon the role of mentors in this kind of difficult surgery. Just like we do this in many games, surgeons, in many ways, it's a team sport, and surgery is a team sport. And so before approaching a difficult operation, you have to really regroup and think about all these things and make a plan. One of the things about the imaging is we have to be very careful about what imaging you're going to get, not throw everything at the patient, but do the imaging that you're going to act on. Auditing a previous surgery is one of the most important steps. And you have to really sit down with yourself and maybe sometimes with your colleagues or experts to audit your previous, either it's your surgery or someone else's surgery, to sort of know what was done and what the problem is, how you're going to reapproach this. And sometimes for this, you need to have landmarks which are either defined from the previous surgery, or sometimes if they're not defined and you have to do some imaging. Many times you don't have times and you have to do them on an emergency basis. So we're going to quickly also look at that. I included endoscopy in imaging, and we will discuss this a little bit more, but I strongly believe that endoscopy is a surgical skill, and it adds a lot of value to a foregut surgeon when we're trying to do any foregut surgery, but particularly redo surgery. Other things that we would include will be barium, a CAT scan, gastric emptying, and high resolution manometry. Endoscopy, as we all know, can be super important, and it's important to differentiate whether it looks like a tight wrap or too tight wrap, or if it's, for example, a fundoplication that's given away, or in the other pictures here, a mesh sticking out. That adds a lot of value, because no imaging is in terms of actually CT scan or barium can tell you that the mesh is eroding like this into the lumen. Barium studies are a lost art sort of these days, but they can be super important. It can be most crucial form of imaging. It can define the new anatomy and many times also physiology. So studying both is super important. Here is a couple of imaging. As you can see, it not only can tell you about the motility, but in the figure B, you can tell you about the slipped wrap that has gone above the diaphragm, or sometimes even the orientation of the stomach per se. Couple more imaging of the extreme sort of cases of hiatal hernias, where as you can see, the stomach is completely rotated around its axis here. And that can explain not even just the symptoms of the patient, but that can also determine how you're going to approach sort of redo the surgery. CAT scans are very important, especially for studying the pressure effects, also to rule out other pathology, and in emergency cases about the viability of the stomach and perforations. For example, in this case, the pressure effects on the heart are very clear. In the second picture here, as you can see a lymphoma which has been diagnosed, which is actually could not have been seen other way. So there are obviously other roles of the CAT scan. In an emergency situation, it can detect either mesoaxial or organoaxial volvulus of the stomach. It can also tell about the viability and perforations of the stomach. And so studying the CAT scan and reading your own images has been shown to be extremely important in these cases. This is a CAT scan where you can see that there is actually a contained perforation of the stomach within the volvulized stomach. If you have time, obviously not in an emergency case, it's very important to study gastric emptying. It can be studied in different ways, but one of the ways to do is either barium studies or nuclear medicine imaging, both in solid and liquid phases. And importance of assessing it pre-op is super important because that can also significantly affect your post-operative outcomes of a redo surgery. And whether you want to plan a pyloromyotomy or some other intervention, such as POP, which is per oral myotomy without incisions. High resolution manometry can add a lot to the whole picture, and it's an important measurement of esophageal function. We use high resolution manometry significantly. In fact, I'm big on even training our fellows about reading high resolution manometries on our own, because it can really diagnose both mechanical as well as some physiological problems of swallowing. The newer tool on the block is EndoFlip, which is an intraoperative measurement of how the LES functions, and can be super helpful to give intraoperative feedback as you're redoing a hiatal hernia surgery. This is a separate talk altogether, but we find that this tool is super important in redo surgeries. Now coming to the technical and procedural pearls. Obviously, you have to address some of the adhesions from the previous surgery. As you all know, typically we can go through the adhesions either laparoscopic. You all are excellent laparoscopic surgeons, but I find that the robotic platform can be super helpful for redo surgery, especially for adhesions and some of the finer technical dissection. We're going to see some video about that. Identifying the landmarks is, again, very important. There are different ways to address the hiatus. It could be from the right side, defining the right cruise by opening the gastrohepatic on the right, or going from the left. And many times there is no right or wrong approach, because redo surgery is more like navigation, where you take one approach, and if that fails, you take the other approach. The goal is to ultimately go to the hiatus. And so however or whichever way you can go, there is no right or wrong answer. Typically, all surgeons are creatures of habit, and we try to do one approach rather than the other, which is absolutely fine. You have to define the previous anatomy. Just like I said, the previous game plan has to be in the back of your head as to what you're trying to achieve. If there is a previous fundoplication, there are two ways to address this. Sometimes, again, if you are doing intraoperative endoscopy, this helps significantly. But if you are not, then you have to make sure you talk to your GI colleague and look at the endoscopy report to determine how is the fundoplication previously and whether it makes sense to redo it or not redo it. Hypothetically, if the fundoplication looks good, then you can try to preserve it if it's possible, versus you can take it down and redo it. That's something that you have to be prepared for. Many times you enter into gastrotomies while taking this down, but typically that's not a big deal. You can either suture it or staple it if you can't suture it, and usually doesn't add a lot of morbidity. Mesh versus no mesh is always a big question. The short answer is we don't know. However, the decision is made intraoperatively depending on how the quality of the crura looks like. We are actually starting a very big prospective trial in these cases. And so if any one of you want to join the trial, please contact me individually. We'll be more than happy to include you in this Harvard-led study. We already have multi-center sign-up process for this, but if any one of you want to participate, let me know. But the short answer is we really don't know. We know for now that the mesh does give short-term protection. However, mesh is not without complications, and we're going to see a video actually that mesh can be actually dangerous. Intraoperative EGD is super important. Again, I feel that doing it in real time helps me to decide on a lot of things, including how the wrap looks, how tight the wrap is, and just defining the anatomy, particularly in the redo case. Role of mentors cannot be underscored more. This surgery technically can be challenging. The planes can be deceiving. And sometimes you need another pair of eyes to just look at everything. One of the ways to do that is to record all your videos and have either yourself or someone else look at it to sort of keep talking about it, because we all learn through videos a lot. One of the platforms that we've been using on a video is a very great collaborative platform called Instrumentor. Again, if anybody wants to join that, we're happy to collaborate on that platform. If anyone wants to know more, I'm happy to talk about that as well. It's called Instrumentor. With that, I think we're going to see a video. I'm going to stop sharing this and share a different video here. 1 second. So this is a robotic redo case. As you can see, there are a lot of adhesions from previous surgery, and typically you have to just take your time to slowly go through all the adhesions. Typically, it will come with its own challenges of some bleeding. As you can see here, there's not even space to put a Nathanson retractor yet. And we have to slowly work on the lower surface of the left lobe of the liver to get the previous stomach as well as the other adhesions down. The robotic platform can help sometimes to have the ICG to sort of, in a difficult case, to see where the liver is and where the stomach is. Sometimes is not that clear. I'm going to skip the video just a little bit. I also use a 4x4 typically that helps during the case and prevents any assistant to put in a suction apparatus. So this is typically, once you know where the stomach is, it's relatively easy to take down this fatty adhesions under the left lobe of the liver. Here I'm using a device called Vessel Sealer, but we do have a new device called SynchroSeal. Any one of those are great. The SynchroSeal can help with finer dissection, and it's a little bit faster. But this is done with Vessel Seal. Now I've put the Nathanson, as you can see, and now we can make some sense of the thing. This case actually, just to give you a perspective, was done in a patient who had very, very significant dysphagia after a previous fundoplication and hiatal hernia repair done at an outside hospital. We have done previous imaging that showed that the mesh and the hiatus was super tight at the hiatus. And so here you can start seeing the left cruise over here. And now I'm on the right side, but you can see some sort of some sides of a previous mesh. We're going to see that slightly more as we go forward. I'm going to, again, for the lack, because of the time constraint, I'm going to forward the video here. I'm addressing the mediastinum. You have to, just like anything else, you have to mobilize enough in the mediastinum. Usually this is not a very clean surgery as a virgin hiatal surgery, as now you can see the right cruise is encased with the mesh. This step actually, I had actually cut the mesh here at 12 o'clock position just to even approach. As you can see, this is even now super tight around the esophagus. The mesh continues. This is the leading edge of the previous mesh. And we are going posterior and behind the esophagus here to identify the junction of the left and right cruise. Typically, I don't use a Penrose, but in this case, I did. Many times to redo surgery, Penrose is very important to sort of define things and get them away. In a virgin Hadolf surgery, I typically just get away with one of the robotic arms that can retract the G junction for me. This is a trick that we use commonly to just perforate the Penrose so that you don't need a clip or anything, just go through it and you can withdraw. Here's a tight Hadis again that we're dissecting. A lot of adhesions, as you can see. I'm going to forward the video just a little bit. So still dissecting the mesh, I'm cutting the mesh. Now is the time to do an endoscopy. You can see a picture-in-picture image. There's a lot of food stuck in the esophagus, as you can see in the video, in the picture below. So that tells you that they're still very tight. This is the previous fundoplication, as you can see on the top, that the fundoplication is here. This patient had a preoperative endoflip as well that showed tightness both at the hiatus as well as at the fundoplication. So this is the scope trying to go through the fundoplication. Is still, as you can see, it's not going easy. Here I'm taking down the fundoplication, and as we do, it sort of does then go through. So with some difficulty, as you can see, you can go through it now that I'm in the stomach with my endoscope. So typically either one of my fellows or one of the residents helps me with this step, but I like to do the endoscopy actually in this part. Here's the fundoplication being taken down completely once we know. Again, in this case, many times you can't even see where the vagus is. You do your best to sort of stick to the stomach. Here we are taking down the fundoplication completely. Many times you can do, sometimes there are anerotomies in these cases, but that can be repaired, like I said, easily. We're gonna move forward just a little bit here. This is where we're doing another endoscopy. I'm just gonna forward this a little bit. So now the fundoplication completely being undone here. And essentially at the end, we ended up, as you can see, the Hadis is now clear. The mesh has been cut open. It looks much better. And then we very loosely closed the Hadis and actually did not do any further fundoplication, as it was not needed in this case. So this relieved the patient's dysphagia significantly. And it was a much better outcome. So with that, I would like to take a pause. I know I can go on and on, but I'm sure Professor Wong will not like me for taking his time. So thank you so much for the opportunity. Happy to take any questions. And it's been a privilege. Thank you again.
Professor Charu, we have our very senior professor, Professor Ajay Kumar Kriplani. He is right now the head of the director of and head of the department of the GA and minimal access surgery of Fortis. So, Dr. Kriplani, sir, would appreciate if you can give your comments and ask a couple of questions. Sir, you are in muted motion, sir. Please unmute yourself, sir.
So thank you, Dr. Kanagave.
Yes,
And we had a wonderful lecture by Dr. Charu, and we learned so many things about redo bariatric surgery, redo fundoplication surgery, redo anti-reflux surgery. And we were enlightened in so many aspects. At the outset, I would say that every redo anti-reflux surgery is a very challenging surgery. And the challenges are not only limited to the operation theater, but the challenges start from the evaluation of the patient. You have to be extremely careful about what symptoms you are going to relieve. What are the symptoms of the patients? Whether he is being operated for a dysphagia, which is more common indication for surgery, or he's being operated for a persistent reflux, which is less common indication for surgery, because most of these persistent anti-reflux surgeon will prefer to manage by medical treatment, or he has a gas bloat syndrome, or he has a slipped fundoplication, or he has migrated fundoplication, which might require an emergency surgery. So your goals should be very clear, and you should evaluate what are you going to relieve. And it is very important to get as much of information as possible about the previous surgery. Not only after the first surgery, but you should also look into the records of the patient before the first surgery, because sometimes it is extremely difficult to differentiate between achalasia and reflux disease. And I have known situations where surgeons have operated achalasia thinking it to be reflux disease, and it was very, with a thorough investigation, we found out one of the radiology investigation before first surgery, which showed that truly it was actually an achalasia, because once a fundoplication has been formed, and if it is too tight, then we have seen manometric studies really do not help much. Even the motility studies do not help much, because they have been they are flouted by the redo fundoplication, by the inflammation, by the distortion of the anatomy, by a tight diaphragm, or by a tight fundoplication. So the evaluation should not just include your fresh investigation of the first surgery, but even investigations and symptoms of that patient that had before the first surgery. And you should never promise the patients very high results, because if we say that offer a primary anti-reflux procedure, a significant symptomatic relief is possible in 80 to 85% patients. After a redo fundoplication, the symptomatic relief is not going to be so high, and the patient's expectations should not be raised too much. Otherwise, they will feel more disappointed with the results. Technically, we had some very nice points by Dr. Charu, and I would say that every surgeon must assess his own skills, his own setup, to make sure that he has large enough experience of fundoplication surgeries before he embarks on the journey of a redo fundoplication, because it is the most difficult surgery. There's so much of fibrosis, not only at the diaphragm, but around the GE junction. And at times it is very difficult to locate the esophagus, which is covered with dense adhesions underneath the wrap. And quite often we have seen in our experience, we have to undo the wrap completely before we can locate the esophagus. And we have seen, we don't do our own endoscopy, so we rely very heavily on locating the esophagus by calibration tube, so that you can feel and you can palpate. And at the end of the procedure, if required, we call our gastroenterology colleagues to do an endoscopy. But it's truly a very challenging technical procedure. And at best, if you do a best performance, it still is a very messy procedure. So be guarded about when you undertake a anti-reflux procedure, and you will require all the resources available to you to give consistently good results for these patients.
Thank you, Dr. Kriplani, sir, for your thoughts. Dr. Deepraj, would you like to add your comments here? You want to come in now?
No, at the expense of preempting Dr. Wong's talk, I just have one question for you, Dr. Paranspe. Excellent talk, enjoyed the video. When on the one hand, we say that anything that we put at the hiatus or around the esophagus can lead to long-term problems, why then are we chasing down the rabbit hole of LINX devices around the esophagus to control minimally symptomatic patients with GERD? So your comments on this, please.
So I think that's a topic on its own, but in few minutes, I think, you know, every device and every gadget, I think, in my opinion, I'm just giving my personal view, it has its own value in limited situations. However, every company will tell you that you should use it for every situation. And I think, LINX is one of those, in my opinion, it's a good tool when there's nothing to wrap around. For example, in post-bariatric patients, when people have a lot of reflux, or in some other redo procedures, I think it's a good tool. However, using LINX primarily, although the data suggests that it's been, now in experienced hand, it's very safe, yet we cannot ignore the perforations with different series, sometimes up to 2 to 5%, which is pretty significant, depending on which data you look at. So I think, again, I'm not a LINX expert, so don't take my experience from few cases as the expert. But this is my opinion on the LINX, that, again, it has its value in certain cases. But certainly, if you have a natural fundus to wrap around, that would be my personal preference.
Thank you.
Thank you, Dr. Deepraj. Dr. Charu, one quick question before I permit you to leave. I could see the advantage of robot, like the separation between the liver, the hiatal dissection, seems to be much at our convenience, because laparoscopy, definitely we have challenged the posterior dissection, especially we don't have the access to the hiatus at all, somewhere or other. And at least in our department, in our hands, couple of times we had to, we had entered into the stomach as well by the time of dissecting. And there are some schools of thoughts where they don't dissect, they use a stapled division of the fundoplication also. Things apart, with seeing your robotic dissection, do you feel that robot is definitely an advantageous thing, or you have your still preferences to use robot or laparoscopic approach? Can we quickly have a comment on that?
Yes, I've been using the robot since 2009, and I've gone through all its variations. I must say that the earlier variations of the Da Vinci were challenging, but the new XI has been great, and I know it's costly. And I do laparoscopy still a lot. I think specifically for redo, given a choice, I would prefer the robot, just because of the visualization, and most importantly, I think the wristed movements come very, very handy in redo surgery. Like Dr. Kriplani was saying, there are just like usually severe dense adhesions, and typically having a wristed scissor is so helpful in those situations. I think you can just see better and do a lot of dissection better. So for redo, I'm very biased. For I think for virgin cases, and that's just a buyer's choice, I think.
Thank you very much. Professor Kriplani, you would like to have any questions? Or can we move on to the next talk?
No, I think we can move on to next talk.
Thank you, Charu. I think you are in a tough situation accepting to this. But anyway, thank you. And I apologize to both Wang and Dr. Deepraj for making a last moment shift of doing the program. I think Wang is back with us. Professor Wang, would you like to add something to the comments on Dr. Charu? What is your take on this?
Well, my take is that most of the surgeons are avoiding redo surgeries as much as possible. So, so back to the very beginning questions, and on what situation would you prefer the patient to have the surgery, or you continue the pharmacological therapy? I'm just saying in those elective situations, just like a recurrence of the GERD symptoms, for example. So are you going to ask the patient to redo the surgery, or whether you will ask him to continue the medical therapy?
Yeah, I think, as for any other GERD surgery, whether it's primary or redo, we always approach it with the lifestyle and diet modifications first, along with the medical therapy. If they're maxed out on the medical therapy, and or in this patient, she has a severe mechanical problem as a result of the previous surgery, the pills won't do anything to the mechanical problems. And especially if they're severe, you're sort of committed to sort of do something. But I think your question of just operating on for recurrent heartburn or reflux symptoms is an important one, because that typically we stress with my primary patients. If it's someone else's patient, even then, we have them meet our dietitian. If they have BMIs that are very high, then we work with them to reduce their BMIs, continue the medical therapy. And if no other option is there, then obviously redo has been actually in our published reports, as well as many other, including Demisters, have published that the redo surgery in experienced hand can give actually long-term good anti-reflux operations, results. But for mechanical symptoms, for other reasons, for dysphagia, or if the whole thing is detorsed or mechanically distorted, then sometimes you're forced to operate.
Dr. Charu, I have a small question. If you find that the patient has severe anti-reflux procedure and you do an anatomical roadmap by barium and you find that there's really anything wrong with the fundoplication, will you still consider surgery, or you will just keep that patient on medical treatment? Or you will reserve redo surgery only for those who have a demonstrable anatomical distortion?
Yeah, so if they have a significant reflux, like proven with either, ideally with a pH study and correlating with their symptoms typically, then, first line, obviously in the short term, always is medical therapy with weight loss and diet control. However, hypothetically, if the patient is very young and doesn't want to be on PPIs, and or if they're having multiple breakthrough symptoms and or mechanical or volume reflux on top of all this, then you can consider redo, considering there's all these other steps are done. So I think the first line would always be maximal medical therapy with diet and activity modifications. But then later on, you can consider, depending on what their quality of life scores are. I keep, so our center, as well as many others, we keep the quality of life scores related to reflux from pre-op to every single visit. And so I have like documentations and their quality of life score charts for years on every patient. And so that can tell you sort of where they are. And that is the important matrix to go by, because many times then you can reflect back on their quality of life and say, here you were a few months ago and here you are now. And that helps even them to look at it very objectively than just subjective decision making.
Thank you.
Thank you very much, Dr. Charu. Thanks for your time. And I think we will excuse you to go ahead with your work for the day.
Thank you again. Thank you.
Thank you. Ladies and gentlemen, now I move on to the next section. I have the honor of introducing Dr. Deepraj to all of you. He himself does not need an introduction. He has been blessed to start his career along the footsteps of Professor Hampton Woodwardia, the founder president of the Indian Association of Gastroesophageal Endoscopic Surgeons. He has along with Professor Woodwardia sir at multiple places, and later he has set his foot on starting from early 90s, from basic to advanced laparoscopic procedures. Right now, he consults at the PD Hinduja, Lilavati hospitals, and other commitment to him is he was making our journal, the JMAS, the Journal of Minimal Access Surgery, from his baby to this mature, respectable journal across the globe. And he currently occupies the very coveted chair of the president of the Hernia Society of India. And he has multiple commitments, and his teaching channels are a treatise to watch. So I request Dr. Deepraj to conduct this part of the meeting. Over to you, Dr. Deepraj.
Thank you very much, Dr. Kanagvel. It's indeed an honor to be here, and honor to introduce Dr. Professor Ian Wong, who is a professor at in the Department of Surgery at the Hong Kong University. And his main research interests include esophageal and gastric cancer, diagnosis and management of the esophageal motility disorders, including GERD. And he has a special research interest in the post-lung transplant GERD, which is something that we don't really see much of in India. And he holds several important positions in upper gastrointestinal surgical associations in the Asia Pacific region, and is also a member of several of them. Going through his biodata, I realized that he is extensively published in the field of upper gastrointestinal surgery. So without much ado, may I request him to go ahead with his presentation, please.
Thank you very much for Dr. Deepak for your kind introduction, and also IAGES for the invitation, also Dr. Kanakavel. And so in the interest of time, let me share my screen and start right away. So my topic assigned is the anti-reflux operations is surgery giving way to endotherapy. Can you see my slides?
Yes, Professor.
Okay, great. So I have no conflict of interest. So the outline is to talk about the principles which would affect how we choose between laparoscopic or endoscopic treatment, and how's the anti-reflux mechanisms behind of the operations. The limitation of fundoplication, magnetic sphincter augmentation, some of the questions has been asked, and I will try to answer it and introduce some of the endoscopic procedures and their limitations as well. So firstly, we've talked about by Dr. Charu the importance of the hiatus hernia repair and also the sphincter laxity itself. And all of the treatments are treating these two problems. As you can see that we want to reconstitute the flat valve function by fundoplication, either partial or full, either laparoscopic or endoscopic. They are doing the same thing, trying to reconstitute the flat valve effect. The magnetic sphincter is trying to reinforce the sphincter in a mechanical way. So other endoscopic treatment like strata, the radio frequency ablation, or the anti-reflux mucosectomy or ablation is trying to induce fibrosis or tissue remodeling so that they can be strengthened the muscularis propria level. So of course, the other side is the dilated hiatus and hiatus hernia, which can only be dealt with laparoscopically. And the principle is to have lower mediastinal dissection, adequate intra-abdominal length, and the repair with or without mesh. So this is important in this two-hit hypothesis, is that in this study, utilizing the endoflip device that Dr. Charu has mentioned, it's actually a smart bougie where the balloon, as you can see, has a real-time image during the endoluminal image, looking at the pressure and also the diameter of the lower esophageal sphincter. So this is our own image before and after fundoplication, where you can see there is a tightening of the lower esophageal sphincter as well as the lengthening of the lower esophageal sphincter. And this study basically look at the different time points of anti-reflux surgery. So they include 100 patients, and they realized that around 70 to 80% of the what we call the compliance or distensibility is constituted by the hiatus hernia repair itself, and the additional repair by the fundoplication or magnetic sphincter only constitute a minority of the distensibility. And so back to the mechanism of fundoplication. As mentioned, it all begins with the hiatus hernia repair. And with the intra-abdominal length of the esophagus, with the fundus wrapped around the abdominal esophagus rather than the stomach, and reconstituting this valve an angle of His with a short and floppy wrap, where it would increase the basal lower esophageal sphincter pressure, at the same time decrease the transient lower esophageal sphincter relaxation. And of course, there is another postulation, is that it would improve gastric emptying by reducing the size of the gastric volume. Of course, if there's injury to the vagus nerve, it can, on the other hand, cause decrease in gastric emptying. So there are a lot of studies, all these decades have shown that the efficacy, as well as the cost effectiveness, as well as when compared with medical treatment, that fundoplication is not only par to medical therapy, but in some refractory patients can have superior results. However, there are some limitations of anti-reflux surgery. As you can see, as I've mentioned, the dysphagia problem or the Gaspo syndrome problem, it can ranges from 10 to 30% for Gaspo syndrome or 50% for acute dysphagia. So this is the limitation of fundoplication. So want to spend some time on lengths that was talked about. Many people asked about the question whether it would cause esophageal motility problem, just like the angio-check device decades ago, as well as the erosion problem. Usually the explanation is that the force of magnets would be less when they are more separated apart or when there is pressure. So it's different from this silicone device, like the lap band or other devices, which is non-compliant. The larger the force that applied on the band, there will be higher force pushing back into the esophagus and causing erosion, causing also dysphagia. And the length or magnetic sphincter device is designed to withstand the gastric pressure, but not the peristaltic pressure. So this is very ideal. However, there's still dysphagia after a magnetic sphincter, and we will talk about it later. So again, for comparison, the efficacy has been well studied in terms of symptoms, as well as the objective monitoring by PH study published in New England back in 2013. So it has been 10 years from now. So the results is long-term results from 5 years, as well as from 12 years, is also showing that the anti-reflux results is persistent all through these years. And when compared with standard, which is PPI, medical therapy, when we're looking at the regurgitation symptoms, of course, it's well known that PPI can't really tackle regurgitation. And when we have retrospective comparison with the fundoplication, the efficacy is similar. However, the ability to belch and ability to vomit or the Gaspo syndrome is significantly lower. So it was FDA approved back in 2012, and in Asia we have introduced it like 3-4 years ago, and later followed by Singapore. And this is a short, brief video. I'm not sure if it is smooth, but we can try. So just to say how easy it is to be done. So this is the hiatus hernia. So similar to all hiatus hernia repair. Maybe I'll skip the initial part. Basically, it's the most of the part of the time you spent on hiatus hernia repair. So here is the vagus nerve, and we create a window between the esophagus and the vagus, and then we would insert what we called a sizer into this window to check the size of the esophagus. And this is very important because later the study has shown that the smaller the size or the smaller the number of beads of the magnetic sphincter will cause a higher dysphagia or erosion rate, which is not surprising. And the pop size, we add on 3 number of beads, and the final product is as simple as that, clips on, and the procedure is done. So there is less suturing and less manipulation and less technically demanding of variation between high volume or low volume center. So this is the image of the length. We can very easily shows that there's no migration and there's no recurrence of the hiatus hernia just by simple imaging X-ray planes, X-ray like this. So initially, there are a lot of precautions according to the initial study. So all of these hiatus hernia, a motility disorder, and so on. So I will select a few and discuss them. For hiatus hernia, the initial protocol of lengths is not to repair the hiatus hernia. So the results was less favorable, and basically those with hiatus more than 3 centimeters was excluded from the indication. However, now FDA has have also modified the indications and allowed hiatus hernia more than 3 centimeters because of the study afterwards that in concomitant repair of the hiatus hernia, the results of magnetic sphincter is even better than those without hiatus hernia. So these evidence have caused the FDA to amend the indication for surgery. So hiatus hernia now is no longer a contraindication for magnetic sphincter augmentation. So we have also discussed about where there is no fundus, for example, in sleeve gastrectomy. So if there's a persistent reflux, as many of us believe that sleeve gastrectomy would cause gastroesophageal reflux disease, would links be one of the options for these patients instead of going to convert into Roux-en-Y gastric bypass. So again, more and more studies have come out, and there will be a larger scale study that will be presented in American Foregut Association later this year, and we will be eagerly awaited. And some even propose to have the magnetic sphincter augmentation at the same time of bariatric surgery, but it was heavily criticized because it is, after all, a foreign body, and at the time of bariatric surgery, there may be some minor contamination and cause problems. And not all bariatric surgery will have GERD, so they will be overtreating many patients. So lastly, the symptoms of dysphagia or problems are the risk of magnetic sphincter. As you can see from here, the quoted erosion rate is 0.15%, and the dysphagia rate in long run is 7%. However, when you look at the immediate after implantation, the patients have almost 70% of them have acute dysphagia. Most of the reason is that there will be initial adhesions around this foreign body, and if the patient does not have a what I should say, a physiotherapy for the lower esophageal sphincter, which is basically repeated swallowing or eating, then the scarring will be very fixed to the size of the lower esophageal sphincter and cause dysphagia. And as mentioned previously, the size of the links is chosen to be smaller in size, and there's a change in sizing protocol in 2018, and afterwards the incidence of dysphagia has dropped drastically, and it also correlates to the size of the number of beats of the magnets. And there are some protocols for managing dysphagia after magnetic sphincter augmentation, and advocates the diet exercise that I've mentioned in early phase. And in late phase, there can be multiple dilatation or steroids injection, and eventually an explant. So as you can see this from this publications, the smaller the size, the higher the erosion rate. And there's no longer size 12 nowadays. The smallest is size 13, but also weaning out in America. And we ought to have larger size of the magnetic sphincter, where the anti-reflux effect is preserved. And the majority of explants are due to dysphagia. And for this, erosion is rarely happens nowadays. So this is a protocol of how we manage our patient. We have symptoms evaluation. We do all three investigations, including endoscopy, pH monitoring, and as well as a high resolution manometry. So we haven't got any achalasia being put on a wrap before. And we will study the results and then counsel the patient and offer either a toupee or partial fundoplication or a magnetic sphincter augmentation with intraoperative endoflip. And post-operative 6 months, we'll repeat the above investigations and looked at the symptom scores as well. And just to touch on the other side, endoscopic options. So the most studied endoscopic option would be this transoral incisionist fundoplication. So it has a lot of different versions, and now this is called a T 2.0, where there's a mimic a fundoplication in that there's a 270-degree, 3 centimeter to 5 centimeter wrap, where the endoscope is inserted in the lumen of this device. And the patient is put on general anesthesia, and they can so-called tackle a small hiatus hernia by pulling down the full thickness gastric wall by this helix. And the different version of TIF differs from their stapling or their different anchoring mechanisms. However, the concept is still the same, and still the esophagitis, large hiatus hernia were excluded even for now. The quota success rate was 72.7% with those with PPI responsive GERD, even at 59 months. However, when we look at the overall results, and it shows that only the symptoms were commented to be controlling, but the actual exit exposure by objective means were not significantly improved. And towards later on, the PPI usage increased back in time. So in general, TIF is less effective in long run than the traditional laparoscopic surgery. Not to say hiatus hernia patients are excluded. And therefore, nowadays, some endoscopists, I should say, would advocate a conjoint surgery whereby the surgeons can do the hiatus hernia repair, and at the same time, the endoscopist can do a TIF. But personally, I find it a little bit funny, because we have already gone in the laparoscopically. Why don't we do a fundoplication laparoscopically? And some argument is that there will be less gas bloat syndrome. Well, but there's no direct comparisons to those with partial fundoplication. So the guidelines from different society, ESGE, and also ANMS has commented that TIF can be an alternative. They can't be recommended as the lack of long-term data, and also only advised in very selective kind of patients, especially those with not without any hiatus hernia. And there are also remarks that exit exposure times are not normalized. So for other, the rest of the endoscopic options are less studied, but they are quite fascinating to know. So firstly is the strata, which is the radio frequency ablation with augmentation of the lower esophageal sphincter, which they hope to hypertrophy the muscularis propria and reduce the TLESR. It has been approved by FDA in 2000, and for those with no hiatus hernia or those with hiatus hernia less than 3 centimeter, and it says that the symptoms seems to be maintained after 10 years. And secondly is the anti-reflux, initially mucosectomy and now developed into ablation. It's developed by, first reported by Inoue, also Japanese endoscopists, famous surgeons famous for POEM procedure in 2014. And initially, he was doing endoscopic resection for dysplastic barrettes, and noticed that the fibrosis after the ESD or EMR has improved actually the shape and also the symptoms of the patients, and therefore developed this technique. Initially, they have a lot of stricture and needing dilatation. And since EMR is also still a bit technically demanding, it has later advocated to have this APC, ion beam ablation, so that it can be easily adapted. And it was quoted that the successful rate is 73% in 3 years by this meta-analysis, but what is defined by success is varies amongst different studies. And the most common side effects, again, is dysphagia requiring dilatation. And there are 4 patients out of these 460 patients with perforation. And lastly, just to amaze you guys, how Inoue have done this notes procedure. So he tried to do a same session fundoplication endoscopically after POEM. So he did an anterior POEM, which they have a full thickness myotomy, where the endoscope can go into the peritoneal cavity, and they localized the anterior wall of the stomach, and then put on some either endosuture or endoclips with endo loop. And then after closure of the loop or the tightening of the suture, the anterior wall of the fundus is going towards the lower esophageal sphincter, having this shape of anterior partial fundoplication. So just as mentioned, these are less studied or no concrete evidence. And other guidelines, like the ACG guidelines and also AGA guidelines, which were published last year, 2022. Just to summarize, they consider MSA, magnetic sphincter augmentation, as an alternative to fundoplication who failed medical treatment. So they are considered more or less equivalent. And they advise against strata because there's lack of evidence. And for TIF, it's reminded of those precautions and only for those who don't want surgery. And for AGA, the comment is that only TIF is only effective in those with very carefully selected patients. I guess it's due to the esophagitis and also the hiatus problem. So in conclusion, we believed in this two-hit theory where we need to tackle the hiatus as well as lower esophageal sphincter. And there is limitation of fundoplication. Magnetic sphincter has shown to be effective, safe, and potentially less complications or side effects. Endoscopic mostly is TIF, and now gaining popularity with the hiatus hernia repair, although I still can't answer why. But despite that, there is still lacking popularity in terms of limitation in those with esophagitis, and with those pure endoscopic surgery, hiatus hernia is the Achilles heels of Achilles. And therefore, we think that the patient selection is the key for any kind of anti-reflux procedure, and the patient has to know the potential risk and benefit of each, and to decide which operation is the best for them. So this ends my presentation, and welcome any comments and questions.
Professor Deeprat, sir.
Yeah, thank you, Dr. Wong. That was an excellent overview of all the procedures that we have currently available. Out of these, links seems promising, but as I said, I mean, the history of devices around the esophagus, right from the angel chicks prosthesis that you had on one of your slides, has been marred with the long-term complications. I mean, links has been around now for 3-4 years. but we do not really know what the long-term effects of any device around the esophagus. We had the same problem with the gastric bands for bariatric procedures, which went out of fashion. So I'm still a little concerned whether, as far as possible, if you can use a natural fundus, and some of the issues related to dysphagia or long-term gas bloat, etc., can be obviated if one creates a partial wrap in the form of a toupee rather than a complete wrap as nascence. So I think there's still a long way to go. In addition to that, in a country like India, the cost is always a factor. So any of these devices, when the cost comes in, and the patients, when they have any procedure, by and large, I'm sure it's true for you as well, that they want long-term durable results. The patients rarely accept that you would have something done and maybe in 3-4 years' time you would need to revise it, because a lot of patients still pay out of pocket. The insurance cover is not very widely available in India even today. So I would reserve the some of these procedures for very, very select group of patients, with the full understanding that they have not yet been used widely enough to be recommended routinely.
Well, my response to it, there are several points. Firstly, is the comparison between partial fundoplication and links. I'm sure I totally agree with you. That's what we're doing, either two-way fundoplication or links, and where there's no head-to-head comparisons. But when we talk to the esophagologists in America, they are very against the fundoplication because they think that it's not physiological. The point is that the beauty of magnetic sphincter is that the fundus is preserved. For example, in situation in high incidence of gastric cancer, the fundus is naturally cannot be screened if we are doing fundoplication. And as you can see from the video, the procedure of links or the sizing procedure is very standardized. So, well, technically, the high volume center is good as long as they are good at hiatus hernia repair. A consultant doing it or a trainee doing the same procedure will have the same results. So this standardized protocol is also one of the good thing about this procedure. So for the price, well, there are some studies in America saying that magnetic sphincter is even more cost effective in terms of there will be less reoperation or less readmission for problems. And I'm sure there will be more, I mean, for example, in mainland China, they are doing their own magnetic sphincter. Maybe with competition, there will be less pricey. However, another problem is the whether it's MRI compatible. So right now it's compatible to 1.5 Tesla MRI, but with more and more advanced and powerful MRI like 3 Tesla and above, it won't cause any harm to the patient. However, it will demagnetize the device so that the device will stay behind in the patient's body, but there will be no magnetic force. And about the complications from erosion or the esophageal motility problem, I think this design is especially targeting at the flaws of the previous versions, like the angiochicks or the lap bands, in that this compliance is, as mentioned, the higher the force you applied on the magnets, the lesser the force with the magnets pushing back onto the esophagus. And with the latest sizing protocol in using larger size, there will be less and less erosions nowadays. And the trend can be seen in later, more recent publication than the old publications. But I think they are, well, the device is FDA approved in 2012. So right now it's more than 10 years now. And the more and more publication is still coming up, which is still favorable to this device. So I don't have much preference over this device over partial fundoplication, especially for the cost. So usually I would talk to a patient and let them choose. Luckily in Hong Kong, the magnetic sphincter is still covered by the university as a research tool, so the patient doesn't need to pay. However, in long run, if more people are using this device, there may still be a cost problem. So these are my comments for your questions.
Thank you very much. Any questions from the audience? Do we have any questions in the chat box or on the platform, Dr. Kanagwal?
Yes, sir. Professor Wang, like if you are having all the options in your hand, so you categorize very clearly how do you choose your patients and what therapy for that. But in current scenario, if the patient comes with a failed medical therapy, which has been given a long try, I'm talking about particularly failed therapy, not a responded to the medical therapy. They have tried all the possible medical options. Weight loss options have been exercised, diet therapy have been exercised. Still the patient comes to you with the symptomatic reflux. What will be your ideal first surgery of the choice? What will be your option? Do you give the option to the patient, or in your department, it is the MDT perspective, the patient gets what is the best?
Well, we have to be very careful with these patients because, as we all know, refractory to medications can imply a lot of things. It can imply the genuine reflux load, or it can imply the patient may have some kind of functional psychological problems. I spent 3 months in Chicago with Northwestern, and they always taught me when not to operate. So, well, I would counsel the patient very carefully. If they have objective symptoms and they have initial response to PPI, now refractory, with typical symptoms, with anatomical problems like hypertonia, all these checkboxes has been ticked, I will offer surgery. But for which surgery, I will still talk to the patient. Firstly, is the motility. For patients with intact esophageal motility, they can choose both magnetic sphincter or fundoplication. But those with suboptimal or ineffective esophageal motility will shy away from magnets because the mechanism of the magnets needs certain pressure, designed for certain pressure to open up the sphincter. So this is right now the criteria that we will would make. Otherwise, we would just lay out all the risks and benefits of the two procedures and let the patient choose, because we believe that the efficacy is somehow similar for partial fundoplication and magnetic sphincter. Of course, for those with very severe, well, there are also evidence that complete fundoplication have the best anti-reflux results, with the price to pay is the higher rates of dysphagia. So right now we still, and we believe that in Asian patients have poorer esophageal motility somehow. So we tend to do partial fundoplication. But for Caucasian that are living in Hong Kong, we may also consider a full rep, which is basically easier than a partial rep with less suturing needed.
Considering the expertise now people are having in advanced foregut laparoscopy, what do you think is the learning curve for someone to start doing the LINX operation?
Well, as mentioned, the LINX operation is basically much simpler than fundoplication. The most important part is actually the hypertonia repair. So the principle is still whether we can we are comfortable to do the lower mediastinal dissection to attain a adequate abdominal esophagus length. So for us, we are doing cancer surgery. We're doing cancer of the cardia and total gastrectomy. Many times we'll do lower mediastinal dissection, so that won't cause much of the problems. Well, actually, in Hong Kong, the incidence of GERD is not that great as in the Western countries. So we have around 4% that. So in America, that's 15, 17, 20% of symptomatic GERD. So in Hong Kong, it's just like single digit. So we don't have that a lot of patient number, but we are very comfortable for the procedure because of our experience in the cancer surgeries.
Thank you very much, Professor Wang, and I apologize once again for disrupting your schedule and making you stay for a longer time with us. And can I have the honor of inviting our National Secretary, Dr. Satish Midha, to give his comments and propose the word of thanks.
Good evening, everybody again. So it was a great learning experience on this important topic, which we come across in our practice. And we know the incidence of GERD is increasing, and we have to select our patients judiciously. And as that rightly said by Dr. Wong, whom not to operate. This is very important because many a times, if the wrong selection is made, patients sometimes become worse also. So I think it was a great learning experience for all of us. So I would like to thank from the IAGES family, Professor Yan Wong, for his time which he has given, and he has given insight into the whole topic, the latest advancements in the future and the studies which are going on. So we hope that in future we'll be offer more remedies to our patients. Thank you, Dr. Charu Pranje, who has left, and he has also given about the redo surgeries, the difficulties which we face and how to tackle with those problems who have recurrence of symptoms after surgery. Thanks, Professor Deepraj Bhandarkar and Dr. Kriplani for moderating the sessions. Thanks our President and moderator of this whole scene prime time, Dr. Kanak Vail. Also Deep Goyal, who has also left now. So thank you everybody. Thanks those who have joined. Good evening and good day to all of you.
Thank you. Good night.
Thank you. Thank you very much. Bye-bye.
Bye, Professor Wang.
Bye.
Bye. Thank you.
Thank you, DocPlexus team, for giving a flawless platform. And we can call the session a close. Good night, everyone.
Yeah, thanks. Thanks, whole
Bye-bye.
DocPlexus.